All right, welcome everybody to the third International Deprescribing Journal Club session today. We're really excited to be here today. We've got attendees from around the world. We actually had a massive interest in this session, so we're excited to host it from Australia. And the structure mainly will be a presentation that's led by Dr. Daniel Hoyle, followed by a Q&A session, and then we'll have a bit of a wrap up. But to start off with, I'd like to explain why we are all here today. So the International Journal Club came to life last year in the second half of the year. And the real purpose behind it is to try and build partnerships and connections and allow researchers around the world to have the opportunity to network with each other, to discuss and share and collaborate. But also it's an opportunity and a platform, especially for early career researchers who are interested in this space, or even mid-career researchers and beyond who are interested in the field of deprescribing, to really gain more knowledge and understanding of what else is going on around the world. So as a kind reminder, this session will be recorded and is recorded, as you can see. The recording will be available on the CADeN YouTube channel and the Deprescribing Network website. So please be able to, you'll be able to share it with other people and your colleagues and peers if they were unable to make it today. So during the session, please feel free to put in any questions you may have for Daniel in the chat box and react and things. And at the end of the session, Dr. Turner will be able to moderate the Q&A. So that leads me to our introduction. So my name is Nagim. I'm a lecturer at the University of Queensland in medication management. My PhD was focused around deprescribing, and my interest is in patient-centered care, and more recently in developing and co-designing tools for people living with dementia. Dr. Turner is the co-chair of the, I do have it here. Oh. He was the co-director of the CADeN. I'm sorry. He was the co-director of CADeN, and he is the chair of a special interest group in deprescribing. And basically the way that ADEN had started, it was initiated and kicked off by ADEN, the ADEN Journal Club in 2020, in March 2020. And it was really an opportunity to allow other researchers during the pandemic to connect with each other. And then recently, Dr. Turner last year reached out to me with an interest around other networks that we might want to expand this to an international audience. We had really great engagement in our ADEN journal clubs. They were more of a casual style with up to 30 attendees. And sometimes we would have sessions where we would discuss journal articles specifically, and then style of a webinar followed by, a Q&A session that was where we had a special guest speaker. So we would be interested in gaining your feedback at the end of the session and understanding further what further things we can do in order to help support your research portfolios and what style and what content you would like us to cover as well. So without further ado, I'd like to introduce our speaker today, Dr. Daniel Hoyle. He's a lecturer in Therapeutics and Pharmacy in the School of Pharmacy and Pharmacology at the University of Tasmania. His research focuses on investigating clinical and economic outcomes associated with deprescribing in older people and exploring pharmacogenetic-informed approaches to improve the safety of medication withdrawal. Currently, Dr. Hoyle is the principal investigator on a project to improve the management of atrial fibrillation in patients with dementia by examining the utilization pattern of anticoagulants and related clinical outcomes. He's also leading research to study the relationship between variations in benzodiazepine metabolism and the severity and frequency of withdrawal symptoms. So without keeping you waiting for any much longer, I'll just stop sharing my screen and allow Dr. Daniel Hoyle to share his. Thanks.
All right, thank you very much for that kind introduction. So I'm based in the capital of Tasmania, the city of Hobart. And despite being the capital, Hobart is a relatively small city with a population size of around 200,000 people. For context, the entire population of Tasmania is around 540,000 people. So probably smaller than a lot of cities out there. This particular photo, it was taken at sunrise on Mount Wellington, which overlooks the city of Hobart. And I'm currently sitting in an office right around there. So I'm very excited today to be presenting the results for my PhD, or some of the results for my PhD. So I'll just get into it. So thank you for joining me from across the world. Now, whilst there are many things unique to Australia, such as Tim Tams, Vegemite, and drop bears, globally, there is a common concern regarding the over-sedation of residents in long-term care facilities. So for over 3 decades, a high prevalence in the use of antipsychotic and benzodiazepine medications has been reported in long-term care facilities internationally. Now, whilst these medications are also commonly used among older people in the community, their use increases substantially on admission to long-term care facilities, as shown by this figure. So using Australian dispensing data between 2008 and 2015, Harrison and colleagues identified an increase in antipsychotic prescribing from 12.3% immediately prior to admission to 21.3% within the first 3 months of residential care. And benzodiazepine prescribing went from 19.7% immediately prior to admission to 30.5% within 3 months of admission. And similar trends have been shown, or have been reported, I should say, in both Denmark and Canada. So a 2019 study found that antipsychotic and benzodiazepines were being used regularly by about 22% of residents in 100 or across 139 long-term care facilities in Australia, as shown on this heat map. The prevalence of regular antipsychotic use ranged from 20.3% in New South Wales, which is this state around here, to 24.2% in Western Australia. The prevalence of regular benzodiazepine use ranged from 9.6% in the Australian Capital Territory, which is right here, to 27.7% in South Australia. So quite a range here. Among older people, particularly those in long-term care facilities, antipsychotics are commonly used for neuropsychiatric symptoms or behavioral and psychological symptoms of dementia, such as aggression, agitation, or psychosis. And that sometimes shows in both residents with and without dementia. And when used for these symptoms in residents with dementia, antipsychotics have shown modest efficacy with a number needed to treat between 5 to 14. And the use of antipsychotics for other symptoms, such as wandering, calling out, and voiding in inappropriate places, seems less effective. Benzodiazepines are widely used to mitigate acute agitation, anxiety, and sleep disturbances. However, the use of benzodiazepines for agitation is primarily based on clinical experience, given inconsistent results from the few studies available that assess the effectiveness for this indication. Whilst benzodiazepines provide a rapid anxiolytic effect, other pharmacological therapies, such as antidepressants, are preferred long-term, particularly in older adults. Lastly, short-term studies on the efficacy of benzodiazepines for insomnia have estimated a number needed to treat of 13 to achieve improved sleep quality. However, the translation of these results to long-term use is fraught due to the rapid development of tolerance to benzodiazepines, and there's evidence that suggests that the efficacy of benzodiazepines for insomnia may diminish in less than 4 weeks, particularly for shorter-acting agents. So the use of antipsychotics and benzodiazepines, particularly in older people, is associated with severe adverse effects. Antipsychotics may increase the risk of falls, movement disorders like Parkinsonism and tardive dyskinesia, and pneumonia. The FDA has also placed a black box warning on the use of antipsychotics for people with dementia due to the increased risk of stroke and death. Benzodiazepines may also increase the risk of falls and fracture and can contribute to confusion, pneumonia, and there's possible links here with an increased risk of dementia and cognitive impairment. So considering that antipsychotics confer only modest benefits for neuropsychiatric symptoms and are associated with severe adverse effects, clinical guidelines generally recommend reserving antipsychotics for significant agitation, aggression, or psychosis where non-pharmacological therapies are ineffective or where there is a risk of harm to the patient or resident or others. If used, antipsychotics should be reviewed every 12 weeks with the aim to use the lowest effective dose possible. It is important to remember that neuropsychiatric symptoms do change along with changes to the underlying condition, such as progression of dementia or with the removal of a trigger for that behavior or psychological symptom. As a result, antipsychotic prescribing may initially be appropriate, but may be superfluous with time due to changes in symptomology. Benzodiazepines should generally be reserved for people with insomnia or anxiety that is unresponsive to non-pharmacological therapies, or if required for short-term relief of severe agitation. Generally, benzodiazepine use for insomnia should be limited to 2 to 4 weeks to minimize the development of dependence, tolerance, and addiction. On the other hand, when used for anxiety, benzodiazepines can be gradually reduced over 6 weeks. Abrupt cessation of benzodiazepines taken beyond 3 to 4 weeks can result in a withdrawal syndrome. Now, despite these guideline recommendations, studies have found that these medications are not regularly reviewed or deprescribed. An earlier longitudinal study of about 2,000 residents from 40 aged care facilities in Tasmania found that approximately 60% of residents were maintained on the same dose of antipsychotics and benzodiazepines for at least 12 months. In 2016, a study of nearly 600 residents with dementia residing in Dutch special care units reported that only 10% of psychotropic drug use was appropriate. In many cases, this was due to an inappropriate therapy duration. The researchers found that around 76% of residents taking antipsychotics, 91% of residents taking anxiolytics, and 68% of people taking hypnotics were prescribed their therapy for inappropriate durations. Some of the barriers to deprescribing antipsychotics and benzodiazepines, the barriers are quite complex and wide-ranging, and it's somewhat outside of the scope of this talk to talk about the barriers in detail. However, some of the major barriers to sedative deprescribing is the concern of worsened symptoms with subsequent increase in staff workload and or deterioration in resident quality of life. Now, despite these concerns, there is low quality evidence from randomized controlled trials that neuropsychiatric symptoms of dementia are unlikely to worsen upon antipsychotic discontinuation. Furthermore, those with mild symptoms may have reductions in agitation with antipsychotic discontinuation. However, care should be taken with people who have psychosis, aggression, or agitation that initially responded to antipsychotic therapy, or those with severe symptoms at baseline, as symptoms may worsen upon antipsychotic deprescription. On the other hand, there are very few randomized controlled trials reviewing the impact of benzodiazepine deprescribing. Results from a small pilot study of about 38 people suggested benzodiazepines can be discontinued with positive effects on sleep quality and midnight awakenings. So many interventions have been implemented to deprescribe antipsychotic and or benzodiazepine medications in long-term care. Whilst most primarily report on changes in medication use, few studies have reported on clinical outcomes for the residents. In 2018, we performed a systematic review. We found that less than half of all interventions to improve antipsychotic and benzodiazepine use in long-term care facilities reported on clinical outcomes. In particular, only one other study investigated the impact that benzodiazepine reduction had on residents of long-term care facilities. So investigation into the clinical impact of these interventions offers the opportunity to mitigate the aforementioned barriers to antipsychotic and or benzodiazepine dose reduction and identify possible benefits associated with reduced sedative use. Considering this, we aim to answer 3 main questions while examining the clinical effects of antipsychotics and or benzodiazepine dose reduction within a multi-component intervention called the Reducing Use of Sedatives Project, or RedUSe for short. These questions aim to investigate whether antipsychotic and or benzodiazepine dose change was associated with altered neuropsychiatric symptoms, quality of life, or social engagement. So RedUSe was a multi-component quality improvement project funded in 150 Australian long-term care facilities. It involved three main strategies. One, being audit and benchmarking of sedative use. Number two, an interactive and didactic education for long-term care facility staff about the benefits, risks, and guidelines for psychotropic use. And this did involve the care staff quizzing themselves using the older age person psychotropic quiz, which has now been validated. And number three, a targeted sedative review for all residents taking regular doses of antipsychotics and or benzodiazepines by a pharmacist, nurse, and prescriber. And I'll just highlight that's a regular pharmacist who performs medication reviews regularly in that facility, and the nurses and prescribers that work in that facility as well. So these strategies were delivered at baseline and repeated at 3 and 6 months. The project is still being delivered to date and has been expanded further. And currently, I think education has been delivered or training has been delivered across 400 Australian long-term care facilities so far. I want to stress that this is a simplified description of an implementation, and further methodological details are provided in the cited NJA paper authored by Dr. Juanita Westbury and colleagues. But I'm happy to take questions later on and answer them where possible. So RedUSe was rolled out between April 2014 and March 2016 across 4 waves over Australia, as shown on this heat map. And our clinical research recruited residents from 28 long-term care facilities in waves 2 to 4 in New South Wales, so this area, South Australia, Tasmania, and Victoria, and also Queensland as well. So a few different spots. Now, the study was an observational longitudinal clinical outcome study nested within the national expansion of RedUSe. Permanent residents were recruited if they were taking regularly charted antipsychotic and or benzodiazepine medication, which were given on a daily basis. However, they were excluded if they had a documented history of a severe psychiatric condition such as bipolar disorder or schizophrenia, or if they were considered end-stage palliative based on advice from the nursing staff. These residents were generally not targeted by RedUSe. So overall, 206 residents were recruited. This included 99 residents taking antipsychotics and 134 residents taking benzodiazepines, with 27 using both. So the residents' neuropsychiatric symptoms were assessed at baseline and 4 months by interviewing the nursing staff with the Neuropsychiatric Inventory Nursing Aversion, or the MPI-NH, and the Cohen-Mansfield Agitation Inventory, or the CMAI, at both baseline and 4 months. So the MPI assesses a variety of behavioral and psychological symptoms, and the total score is rated out of 144, where higher scores indicate the presence of more severe and or frequent symptoms. Results can be further broken down into specific domains, such as sleep disturbances, anxiety, agitation, hallucinations, etc. The CMAI is a 29-item tool which assesses the frequency of agitation and aggression. The total score is calculated out of 203, where higher scores indicate the presence of more frequent symptoms. The residents' quality of life was assessed at baseline in 4 months, interviewing the nursing staff with the Assessment of Quality of Life 4-dimensional tool, or AQOL-4D. The AQOL-4D is a 12-item utility tool which assesses the resident's quality of life across 4 dimensions. The tool also provides a weighted utility score which acts as a measure of overall quality of life. The score ranges from -0.04, which is worse than death, to 0, which is equivalent to death, to 1, which is the best quality of life. Lastly, the magnitude of residents' social engagement, or social withdrawal in this case, was assessed at baseline and 4 months by interviewing the nursing staff using the multidimensional observational scale for elderly subjects withdrawal subscale. So the Moses withdrawal subscale is an 8-item tool which scores with scores ranging between 8 and 32, where higher scores indicate greater social withdrawal. So lower scores are what we're aiming for in terms of improving engagement. So considering the longitudinal nature of the data, only residents who were followed up were included in this analysis. 2 sets of analyses were performed based on whether the resident was regularly using an antipsychotic or benzodiazepine at baseline, and residents taking both class of agents regularly at baseline were included in both sets of analyses. Change in the antipsychotic and benzodiazepine doses were calculated based on changes in the chlorpromazine and diazepam daily dose equivalents, respectively, between baseline and 4 months. Given the study was observational, there was potential for resident characteristics to have differential effects on prescribing, and these attributes may have also contributed to the clinical outcomes that we saw with sedative dose change. Therefore, we used linear mixed effects models to identify baseline characteristics related to changes in antipsychotic and benzodiazepine dose change. These potentially confounding variables were then controlled for, where appropriate, in multiple linear regression models when investigating the association between percentage change in the dose and change in the clinical outcomes. So out of the 921 residents who were using antipsychotics and or benzodiazepines regularly at baseline in the included facilities, we gained consent from 206 residents. So that gave us a conservative response rate of 22%, which is somewhat of an underestimation, considering that we didn't exclude at that point, that 921 number doesn't exclude residents who had severe psychiatric issues or were palliative. Over time, we lost 21 residents through the project, and we had 179 residents with follow-up data that were included in the final analysis. So the demographic details of the 179 remaining residents seemed typical of the average long-term care resident, with a mean age of 85.5. 72% of the cohort were female. Around 58% had a documented diagnosis of dementia, and residents were taking a mean number of 10 regular medications at baseline. So the following log scale graphs describe daily antipsychotic and benzodiazepine doses at baseline and 4 months, with each point representing the dose taken by a single resident at each time point. For residents taking antipsychotics, the mean chlorpromazine dose declined from 42.1 milligrams per day to 35.3 milligrams per day at 4 months. This represents a 21.2% mean decrease. 22% of residents had their antipsychotic ceased, with 14% having their dose reduced, 5% having a dose increase, and 59% remaining on the same dose after 4 months. For residents on benzodiazepines, the mean diazepam equivalent dose declined from 5.1 to 4.3 milligrams between baseline and 4 months, which is a 17.5% mean decrease. 21% of residents had their benzodiazepine ceased, 14% had their dose decreased, and 6% had their dose increased, with 59% remaining on the same dose over 4 months. So over the next several slides, I'll be graphically representing the change in score of psychometric outcomes that we measured by the percentage change in antipsychotic and benzodiazepine dose. Each point represents a change in score for an individual person and a change in dose. The blue trend line has been added to assist with visualization of the overall change. However, it should be noted that the trend line's extension to the right, so this area here and this area here, is limited by a small number of residents who had their dose increased. We have, in sub-analyses, removed these residents to see what the effect was on that trend, and there was negligible effects on the slope of that trend line. So antipsychotic dose reduction in this case was associated with a small but non-significant decrease in the total MPI and CMAI scores. In particular, we saw that the CMAI factor 2 score, the physically non-aggressive behavior domain, which basically assesses things like wandering and general restlessness, tended to decrease with antipsychotic dose reduction. For benzodiazepine users, the total MPI and CMAI score tended to improve, albeit non-significantly, with benzodiazepine dose reduction. Now, whilst all CMAI factor scores improved non-significantly with benzodiazepine dose reduction, the strongest trends towards improvements were seen with the CMAI factor 2 score, again, that physically non-aggressive behavior domain, and the CMAI factor 3 score, which describes the frequency of verbally agitated behavior, such as calling out. So the AQOL-4D utility and dimensional scores tended to improve non-significantly with antipsychotic dose reduction. And the estimate from the regression model indicated on average a 0.01 point improvement in the overall utility score for each 10% reduction in the antipsychotic dose. Again, it is non-significant though. On the other hand, no association between change in the benzodiazepine dose and the AQOL-4D utility score was detected. A 10% reduction in the antipsychotic dose was associated non-significantly with a 0.16 point improvement in the Moses withdrawal subscale, indicating a tendency toward improved social engagement. Conversely, we didn't find an association between benzodiazepine dose reduction and change in the Moses withdrawal subscale for the benzodiazepine users. So in terms of key findings, this study aimed to explore the relationship between changes in the antipsychotic and or benzodiazepine dose and alterations in neuropsychiatric symptoms, quality of life, and social engagement among residents within a sample of long-term care facilities involved in the RedUSe program. The key overall finding is that antipsychotic and benzodiazepine deprescribing within RedUSe was not associated with worsening in neuropsychiatric symptoms, quality of life, or social engagement. Instead, there were trends towards improved physically non-aggressive behavior, quality of life, and social engagement with antipsychotic dose reduction, and physically non-aggressive behavior and verbally agitated behavior with benzodiazepine dose reduction. These outcomes should be interpreted with some consideration of these limitations. First, RedUSe was funded as an implementation project and pure research was not permitted. This precluded the use of a control group, which made it difficult to determine whether the changes in the outcome were a result of the dose change or other time-dependent effects, such as changes in neuropsychiatric symptoms with time. Future prospective studies should, where possible, utilize a control design to overcome this limitation. Second, through the study, we identified interesting trends. However, a larger sample size is required to provide a bit more statistical power to investigate these trends further. Third, a documented diagnosis of dementia was used as a potentially confounding variable in our multiple linear regression models for benzodiazepine users. However, dementia is often underreported in the setting. It would have been more accurate to test for dementia using standardized tests and diagnostic criteria. However, it wasn't within the scope of this project to do so. Fourth, due to an ethical requirement for arm's length recruitment, nurses at long-term care facilities were instructed to identify all eligible residents. And this may have introduced some element of selective recruitment for residents who are clinically stable. And lastly, long-term care facility staff and assessors were not blinded to the previous and current medication use. However, considering we did not find any major differences in our clinical outcomes, it is unlikely that reporting biases has affected our results here. So our findings align with those from similar multifaceted projects, which suggest that carefully considered antipsychotic and benzodiazepine deprescribing is achievable without deleterious clinical outcomes for most long-term care facility residents. These findings can be used to reassure the resident, their family and or legal guardian, and care staff when obtaining informed consent to deprescribe this medication, or these medications, I should say. Whilst there is mounting evidence that sedative deprescribing is unlikely to worsen neuropsychiatric symptoms, it is important to put in place close monitoring during the withdrawal process to facilitate early identification of symptoms or symptom relapse or withdrawal adverse drug reactions. There is some evidence to suggest that patients with higher levels of neuropsychiatric symptoms at baseline, particularly auditory hallucinations, are more likely to relapse upon antipsychotic deprescribing, and increased support may be warranted. Remember, deprescribing is a trial, and the person can be restarted on their medication if symptoms worsen. And that thought process might provide some comfort to those who are concerned about undertaking that deprescription process. Specific symptoms, such as physically non-aggressive behaviors, may be improved with sedative deprescribing, and this could have implications for the care staff. So in our published work, we found trends towards reduced disruptiveness between baseline and 4 months with both antipsychotic and benzodiazepine dose reduction. It's not reported today, and it's currently unpublished. But these trends were primarily driven by reductions in agitation-related disruption with antipsychotic deprescribing and nighttime behavior-related disruption with benzodiazepine deprescribing. A recent before and after study reported similar reductions in care staff distress and severity of neuropsychiatric symptoms over their 12-month follow-up. A tendency towards improved quality of life with antipsychotic deprescribing in our study aligns with that reported in other psychotropic deprescribing programs. However, findings from these other programs support the premise that improvements or maintenance of quality of life are linked to the utilization of non-pharmacological management strategies that promote person-centered care activities and social interactions. In particular, the World trial run by Ballard in the UK found that antipsychotic review alone resulted in worsened quality of life, but that effect was mitigated by the addition of a social interaction intervention. So evidence regarding the utilization of antipsychotics and benzodiazepines in older people is continuously updated. Here, I provided a brief list of some resources that I thought might be a bit useful for optimizing the use of psychotropic agents in older people. Firstly, the deprescribing.org guidelines provide, well, they have several guidelines available that are easy to use with algorithms to evaluate the ongoing need for a medication and steps you can take to safely deprescribe these medications. Primary Health Tasmania has very recently updated their suite of deprescribing guidelines for a variety of medications, including antipsychotics and benzodiazepines, and these guidelines are broadly applicable. The International Psychogeriatrics Association provide in-depth evidence-based guidelines around the management of BPSD or neuropsychiatric symptoms in people with dementia. These were last revised in 2015. However, the IPA has recently been forming several working groups to provide consensus and position statements for a variety of clinical scenarios, including the reduction and prevention of agitation consensus algorithm, which was published earlier in March. And lastly, the clinical practice guidelines for the appropriate use of psychotropic medications in people living with dementia and in residential care has been or is in the final stages of finalization, I believe, if not already finalized. And it's been created in response to recommendations from Australia's Royal Commission into Aged Care Quality and Safety. Now, I've got a list of references here that would help, I guess, a good reading material if you do want to investigate this area further. These slides, I do believe, will be available for you after this session, so you can review these at your leisure. But I just want to, at this point, acknowledge my supervisors who supported me throughout my PhD, namely Associate Professor Juanita Green, formerly known as Juanita Westbury, Dr. Ivan Bindoff, Associate Professor Lisa Clinic, and Professor Gregory Peterson. And these people were all co-authors on the paper that we presented today. We also had statistical support from Mr. Aidan Bindoff, who was also a co-author on the paper. Now, the RedUSe project and a partial PhD scholarship was funded from 2013 to 2017 by the Australian government under the Dementia Aged Care Service Fund. And I just want to acknowledge the support from the government in that aspect. At this point, though, I want to thank you all for allowing me to present to you all today. And I'm happy to take any questions to explore this research in further detail. However, if you have a question that doesn't get answered, please feel free to contact me via my email address right there. Thank you.
I want to say thank you, Daniel, for a great presentation, an amazing piece of work trying to reduce two medications, as you said, that are highly prevalent in vulnerable older adults and lead to significant harm. So great project. Just want to put it out to people, if you want to put questions in the chat box, I will pose them to Daniel one by one. If you want to read them out or speak out loud, put your hand up and I'll keep an eye on the box there, and then I can unmute you and you can ask Daniel in person. But there are two questions in the chat box already. Thank you. So I'll start with those in the order they come in. The first one, Daniel, was from Jeff, who says, thanks for this very interesting talk. Did you use patient-centered tools like documents or leaflets, or specific techniques such as cognitive behavioral therapy for insomnia to facilitate the implementation of deprescribing, in particular for anxious patients?
Yeah, so sorry, I'm just trying to find my notes on this actually. So the project was originally developed by Juanita Breen. So where are we? Here we are. Okay, so it was originally developed by Juanita Breen, but there were lots of different aspects to this intervention. One was to provide patient-centered tools such as leaflets that could be provided for the residents, particularly around benzodiazepine dose reduction, but also leaflets for antipsychotic reduction, which is provided or available for the person's family as well to alleviate any concerns there. In terms of training, the nursing staff received training across a variety, or basically they were receiving training across a variety of different non-pharmacological techniques that could be utilized. They weren't trained, I guess, to deliver a particular type of non-pharmacological or person-centered care technique, because it does vary, I guess, based on the individual as to which is going to be effective. But they were taught about different things that they might be able to implement in practice, and they were left to implement ones that they thought would be will work well for that particular individual resident. In terms of further information for the family, there was an 8-minute video to introduce RedUSe and the key strategies and the benefits for the resident, prescribers and nursing staff available. I think it's still on YouTube actually, if someone wants to have a quick look for that. And we also had reply to sender postcards for relatives, which allowed them to gain access to the RedUSe website for further information, or send back the postcard to receive information via the post as well. I think that was a major part, I guess, around resident engagement and family engagement. Although, if you'd like to send me an email, I can get you in contact with Juanita Breen, who designed this intervention, who I'm sure would be happy to discuss that further. In terms of, I guess, engagement with a prescriber, there was a few different mechanisms we used. One was we engaged with the NPS, the National Prescribing Service here in Australia, to provide academic detailing or educational outreach for prescribers around antipsychotic and benzodiazepine medications to try and, I guess, alleviate those concerns by the prescribers. In terms of concerns for the nursing staff, aside from the training that was provided, we also designated the champion nurse role in each facility, and they were given some training, or more in-depth training than the rest of the staff, and they were given the role to try and, I guess, alleviate concerns at their own facility around reducing the use of these agents. But yes, any further questions you have on that, I'm happy to forward on to Juanita.
Excellent. Thanks for that summary, Daniel. I know I was saying to Daniel before you came online, my pharmacy was involved in this trial what seems like a lifetime ago. And I'll say the lead nurse support was one of the real drivers that I thought, looking at the way that the facility I looked after worked, they really supported the effect that we managed to get. Having someone on the ground who believed in it and had skills and knowledge was one of the big things that improved that. And I guess that's my segue into the next question that came up in the chat box from Emily Reeve, saying, Daniel, can you please share with us what the practical challenges are of running this kind of large deprescribing implementation study? And in particular, do you have any tips for others who are planning to run similar studies?
Yes. So I went to create a particular slide in this area, and I thought maybe it's a bit too much to present today. So I might just bring that up because this is a really important point. So when I guess hindsight is 2020. So there's a lot of things I learned throughout the project. But of course, one of the major challenges I came across when I was looking through the literature is that outcome reporting is really heterogeneous. It limits the comparison and pooling, and it would have been great to have, I guess, a list of different outcomes that would have allowed me to compare with other studies more easily. We now have some publications written after the fact, of course, that provide some guidance around the types of outcome measurements we should be including in deprescribing studies. And for anyone entering a PhD in this area, I do highly recommend looking into these two papers as a good start to, I guess, deciding what kind of outcomes you might want to include. The other issue is around observational research or being an observational trial and having a single arm instead of having a control group. So we're seeing increasingly that studies are utilizing single arms or observational designs when they're looking to projects to review how patients have their medications prescribed and the effects that might have. And they end up comparing, I guess, those who have their medications reduced versus those that don't. However, this ends up increasing the risk of confounding. And it's just difficult to, I guess, say whether or not the effect you're seeing is due to the medication being reduced or due to underlying confounding or unmeasured characteristics from the patient that you can't determine. So this paper released, I think, November 22, discusses different methods in quite good detail around how to strengthen the observational deprescribing research by utilizing some methods such as target trial emulation, which is where you basically apply the design principles from the from a randomized controlled trial to the analysis of observational data, and propensity score matching, among lots of different methods that could help strengthen these types of observational studies and single arm studies to improve, I guess, the robustness of your results. So if I went to redo this study again, or if I went to redo another study, I'd definitely read these papers and try and implement the principles that they recommend. So was there another part to that question? I might have glossed over
I
it.
think we covered it. There was, yeah, what were the challenges and any tips that you have for running future studies? So I think you covered both. I mean,
the only other major challenge is around recruitment, which is really hard in aged care facilities. And I'm sure lots of people have found that before. I mean, if possible, I would have liked to use an opt-out process, but research doesn't generally allow that ethically. But it was a very big challenge to try and recruit residents in this setting. There are a couple of papers that have been written in this area that provide advice on recruitment, which again were after the fact, after this project, but it's a challenge.
Cool, we've got about 7 minutes left, and then 5 minutes just for follow-up after that. So, and a few questions, so I'll fire them off for you quickly. Naham said, great talk, Daniel. Really like the angle of examining the effect of deprescribing on the level of social interaction. She's curious to know, is there any other literature that tells us about the effect of deprescribing on social interaction, and what would be some examples of non-pharmacological approaches that can help to improve social interaction? Everyone's giving you double-barrel questions, Daniel. Sorry about that.
Hey, that's okay. So in the literature, I mean, there's not much in the literature on social engagement and deprescribing psychotropic agents. The very few studies available indicate that there may be some benefit, but there's not much really out there on the effect of deprescribing on social interaction. In terms of non-pharmacological approaches, sorry, did you want to add anything there, Justin? I thought you. Okay. In terms of examples of non-pharmacological approaches, it would be just, I mean, it could be as simple as engaging the patient in conversation. It could be involving them in group activities. Things like that are usually quite effective in improving that social engagement of the resident.
Cool, thank you. Robert, I see you've got your camera on. Are you wanting to ask? You've got a couple of questions here. Do you want to ask them yourself, or would you prefer for me to read them?
I was unmuted, so okay. Hi, everybody. The one question, thanks, Justin. The one question that I had, I was typing another one, is, and I suppose my camera's over here, so I should look this way. I put you guys in that one. You had mentioned about excluding patients near end of life palliative. And one thing, because my work is mostly in palliative care, did you look at any scales? There's a scale called the Palliative Performance Scale that does have some literature supporting that, you know, based upon its percentage, that patient is likely to have X amount of time left. And I was curious if, you know, if you considered using something like that to better exclude those patients closer to end of life.
We didn't use a tool in this case, but that's a really good point, and probably something to be considered in future studies. Due to the use of arm's length recruitment, we would need the nursing staff to make that assessment, and it might have created a greater barrier to recruitment as well in this particular project. But it's a really good point, I guess, around utilizing such tools in future type of projects.
Yeah, and part of my, you know, because we invariably have to use benzos or antipsychotics towards end of life. And I was curious if that kind of might have skewed some of your results. You might have been able, if better able to exclude those patients, you might have been able to focus on those that you might have even been able to show more benefit for.
That's a really good point.
That's it. I'll try to figure out my other question myself because I'm not done typing it yet.
Cheers.
Excellent. Thanks, Robert. Jump back in when you've got it ready. There was one here which I think you sort of touched on, but I wonder if you wanted to add anything else. Donna asked if you could summarize any barriers to review by pharmacists and how they were dealt with. Donna said, sorry, you might have already addressed this. It was late and apologizes.
In this project, I guess we try to minimize some of the barriers to the review process by having it more as a multidisciplinary approach with that nursing staff performing the sedative review alongside, and in many cases, I was sitting alongside the pharmacist when performing that sedative review. So it's very much a collaborative process before sending it to the doctor. I think the challenges that the pharmacists face in terms of the review here is having their recommendation actioned by the prescriber, particularly in a setting where you have high turnover of staff, where the recommendations that might have been provided by that pharmacist may have been, I guess, the care staff might have come to the prescriber and said, look, this patient's behavior is quite high, let's continue using this antipsychotic, and that might have played a part in the prescriber's decision-making rather than the recommendation made by the pharmacist in this process. But I think one of the major barriers would have been the, I guess, getting the prescriber to review that particular recommendation. Knowledge around deprescribing and how to implement deprescribing of antipsychotics is also a barrier, although the education delivered as a part of this program would have addressed a lot of that as well. I'm sure there's many more barriers that I'm not addressing here, and there is some literature on this area as well I've come across before.
Yeah, I think you're right. Knowledge is one of the biggest barriers, and self-efficacy and trying to improve both of those can really help. And building a receptive team, I've found helps with the whole multi-D approach. I think I'll squeeze together a couple of the last questions and say thanks to a couple of people that have talked about social prescribing. Nin's put a link there to work from McMaster University, and Donna mentioned there's something out for consultation at the moment in Australia to include behavioural support. So it's good to see that work is continuing to grow in there. The last question is a double barrel because Debbie asked it and Georgina added onto it. And I think it's probably great to focus on this because we don't often talk about it. And Debbie said that mandatory quality improvement projects are happening here in residential aged care or long-term care facilities or nursing homes, depending on which country you're dialing in from. Do you think that it's going to improve deprescribing, and are there any potential unintended consequences that you see of these mandatory quality improvements coming in?
I mean, there's potential it could improve deprescribing, but I would also be concerned that you may see pressure to deprescribe these medications where they are appropriate as well, and that could be one unintended consequence. The other would be, I guess, deprescribing and then utilization of other medications that are not approved for the treatment of neuropsychiatric symptoms and may potentially be more dangerous. So the use of medications like antiepileptics in place of antipsychotics or benzodiazepines potentially. In our study, we didn't detect any changes in other medications that have been used for neuropsychiatric symptoms, but it definitely has been detected in other jurisdictions like the US and Canada as well. So I'd be concerned, I guess, about substitution as the major risk here. Yeah.
Excellent. That last bit really linked through to Georgina, who said, did you notice any substitution? And yeah, I think what I've noticed, having lived in Canada and worked with people in the US and now back here in Australia, it really does differ for locations. There's a lot of quetiapine used in Canada, depending on the province, and there's a heck of a lot of gabapentinoids used in the US. So I think some of those switches are maybe geographical, or there's context about the country that are driving those changes, which is great comment, Debbie, to say let's be aware that we're not out of the pot and into the fire with something that has no side effects because we haven't used them enough or looked for them yet. With that, I don't think there's any other questions. So if I can share my screen, I just want to say thank you to Daniel. It was a great project, a great presentation about what I think was a really fascinating project. I think you commented many times on saying that, sorry, my screen just went crazy when I shared. It wasn't a statistically significant improvement, but I think that's important to show it wasn't. Patients got worse. Normally, when I consider residents in aged care facilities, they're normally on a downward trajectory. So stopping their medications, their trajectory held straight, which I think is an important consideration when we're looking at deprescribing or using medications that could be potentially harmful in older adults. So my next slide is just to say what's up next. This was our third International Journal Club. Really excited to say that there's 2 more planned for the year. One in May or June from Northern Europe and one in September from the US Deprescribing Research Network. So I've got a little QR code here for you to sign up for NERD, who I have to say has the best logo and the best name for a deprescribing network. Very jealous. It never occurred to me to do that before, but I love it. So they will be hosting, so it's the Network of European Researchers in Deprescribing, for those who don't know what NERD stands for. We'll be sharing the information about their session in the next few weeks. It's going to go in the CADeN newsletter. I know it's going in the ADEN newsletter, and I'm sure that all of the deprescribing networks will be tweeting about it on their social media platforms too. If you want to look at the QR code that's here, you can sign up right now. This wouldn't be possible without, let's be honest, Camille and Nin harassing us to make sure that we got our slides in time, got our title in time. I really appreciate the support from CADeN, but also the support, as Nachan said at the beginning, from all of the networks involved, the European Society of Clinical Pharmacy. Sorry, it's like midnight or beyond in Europe at the moment. Australian Deprescribing Network, NERD, US Deprescribing Network, and the Canadian Medication Appropriateness and Deprescribing Network with their excellent new names. I just want to shout out and say thank you to all their support, and looking forward to the others coming from international. Almost finished. can someone post the poll? Because thank you. I just lost my poll button. We have a poll just to get some feedback on how this session went. Only a couple of questions. We really just want to find out if you were satisfied. Which bits did you like? What's the likelihood of you joining in again? Your feedback goes directly into planning and organising the very next session. So be honest, be kind, be supportive. If you want to lead a session yourself, let us know. Makes organising things better, and people say, hey, I've got a really great topic. So if you want to suggest a topic or anything, the email there, info@CADeN-ReCAD.ca, is where you can send us anything directly to Camille and Nin, or hit us up on Twitter at DeprescribingNet or Deprescribing Network on Facebook. Hopefully I've left that on the screen long enough, because my next slide is just to say thank you, everyone. It is 11 o'clock. So for those of you that are in Australia and need to get to your next meeting, thank you very much for joining. For those of you in the US, on the West Coast, you may probably have other meetings. Otherwise, everyone else who's sort of at 1 o'clock or in the evening, have a lovely evening. Thank you for joining. Thank you once again, Daniel, for your excellent presentation. And we look forward to seeing you in the middle of the year for the nerd presentation.
Cheers. Thanks, everyone.
Thanks. Bye.